I am Jackie Gillman. I am one of the second-year pediatric residents, and I'm doing journal club today. So the article that I chose was Effect of a Baby-Led Approach to Complementary Feeding on Infant Growth and Overweight. Through a randomized clinical trial. Lead author was Rachel W. Taylor. Special thanks to my advisor, Dr. Permashwar, who helped me with this article and getting it all together. So without further ado, we will go ahead and get started. So objectives for today, we're going to discuss the effect of baby-led weaning on future predictors of obesity, review Z-scores and formulas for Z-score, and then we're also going to analyze the application of baby-led weaning approach to our population at Carilion. Just a fair warning, there are a ton of baby pictures in here of little kids feeding, so prepare to just be engrossed in cuteness. All right. I have no financial disclosures or conflicts of interest during this presentation today. All right. So first of all, why do we even care about this article? Why is it important? So especially if you're in general pediatrics, pediatric residents training in general pediatrics, you have to answer questions for all your family members. And I myself have gotten quite a few questions about what is baby-led weaning? Is this safe for my child? Is this something that I should be doing? It absolutely has application in our practice, some more so than others. I think I've gotten this a little bit more at something like our Rocky Mount, and I'm sure Postal's gotten a few more. Jefferson, not as much, which we can go into a little bit later as well. And then we also want to talk about there's a growing obesity epidemic in the U.S. We're always talking about trying to start from a young age. How do we help prevent obesity early in life, especially here in Southwest Virginia where obesity is very prevalent, especially in our patient population. So all important things to consider in this population. All right, so let's talk a little bit about some of the authors that were present in this study. The lead author was Rachel Taylor. She's a PhD. She works in the Department of Medicine at, I'm going to totally butcher this, but the University of Otago in Dunedin, New Zealand. She's head of the Department of Medicine. She's a research professor and care team fellow in early childhood obesity, which, from what I can tell, is just a distinction in New Zealand that she has to ascertain. Previous publications, she's done a lot on just genetic disorders, including mitochondrial disease and genetic causes of obesity, several publications on the Mediterranean diet, and then also how sleep and exercise affect weight management in children. So she's pretty consistent with the baby-led weaning approach, and that's kind of followed along with her other publications. Next author that we would talk about is Sheila Williams. She has DSc, which is Doctorate of Science, I believe, and she works in the Department of Preventative and Social Medicine, again at the University of Otago. She's a biostatistician at the University of Otago as well. Her publications involve, again, a lot of genetic obesity studies, including those on heart disease, breastfeeding and obesity, and then also a couple on baby-led weaning as well, and then also some exercise outcomes on obesity. And then, again, I'm going to totally butcher this name, but this is Louise Santipico. She has a master's in science, and she works in the Department of Human Nutrition, again at the University of Otago. She's a dietitian at the university. She has 15 other publications, several of them focusing on diet and obesity in infants and children. Just of note, this study didn't really have any MDs, DOs, or actual medical doctors on this specific study, but it contained a lot of dietitians, people with masters in science, doctorates in science, and worked in the Department of Medicine. All right, so let's talk about just briefly, as our introduction, what
do you think about that, not having any MDs? Is it a better study because?
I don't necessarily think, for those who couldn't hear, Dr. Finkler was asking what my thoughts were on the fact that this study doesn't have any MDs, DOs, or anything like that. I don't necessarily think that it makes it a bad study. I think it would be helpful for them to have input from people who are actually, in with the kiddos and talking about what was best for them. But I think it's also helpful that they had dietitians, people who have done nutrition as well. All right, so just talking about typical feeding patterns in our infants. So typically, diet introduction for infants is usually spoon feeding, a lot of pureed foods or cereals to start out with, usually around 4 to 6 months. That's changed a little bit in the past couple of years. We've moved a little bit more towards starting at 4 or 5 months instead of waiting until 6 months. Like I said, we often start with cereals and then move to like pureed fruits and vegetables, introducing one at a time to make sure that they don't have any allergies, and kind of progressing through that as well. We usually introduce finger foods a little bit later once the infant is able to use their pincher grasp and be able to pick up the food. And then typically we always tell our parents breast milk or formula until at least 1 year of age, encourage breastfeeding as long as possible, and then they can transition to cow's milk at 1 year. All right, and then just for those who are not familiar with baby-led weaning, this is kind of an approach that I've seen come up a lot more in the past couple of years, especially in our more higher socioeconomic population especially. The theory behind this is that infants are able to feed themselves from the beginning of the complementary food period, so that's about 6 months. And you start with soft foods like avocados, bananas, and essentially instead of spoon feeding, you're having them use their pincher grasp to basically pick up the food themselves and feed themselves alone. Very messy. Parents are not as involved in the fact that they're not spoon feeding the baby as much. You do breastfeed or formula feed until 6 months of age prior to transition, because before that 6 months of age, they really don't have the means necessary to be able to feed themselves at that point. The theory behind this is that infants, they're able to kind of self-regulate a little bit more. They're able to establish like when they're full, and therefore decreasing the risk of obesity later on in life. Because, if you have your parents, they're spoon feeding the baby and you've got 3 bites left in that little baby food jar, you don't want to waste it, so you kind of shove a couple more bites in the baby's face and hope that they will finish it and not puke it up. So, and then they also, the theory behind it is that it helps with some food fussiness, so children are not as selective for it. They have more choices because you're offering them what you're eating, so they have a little bit more opportunity to kind of grasp different types of food and have more opportunity to eat different types of food. Some of the concerns that have been brought up about baby-led weaning, there is supposedly an increased risk of choking. You're not using those pureed foods to start out with. As the traditional baby-led weaning is kind of like I eat what you eat, minus the particular foods like honey and cow's milk and that kind of stuff. So there could be an increased risk of choking with that. And then concern that the infants might not be able to feed themselves enough to sustain their nutrition. So if they don't have the developmental skills to be able to pick up the food, they may not be eating as much because they get tired, or they get frustrated and just don't want to continue feeding. And then the other concern is iron deficiency. So if you're not feeding them the correct foods, you may have a risk of iron deficiency. A lot of the baby foods have some iron in it. A lot of the cereals have iron in it. So if I'm not getting enough iron in my diet, it's very possible that baby's not getting enough iron in their diet if we're feeding the same thing. Okay, let's talk about some previous studies. So there surprisingly have not been a ton of studies on this previously for how popular I think it's become in the past couple years. When this study came out, which is a couple years ago, they had one study at that time that looked at energy regulation and found that between the baby-led weaning and the spoon feeding, they had similar energy regulation at an older age. So they were able to feed themselves enough and be okay with that. And then 2 studies looked at the risk of obesity, and those 2 studies did find that there was less risk of obesity in the baby-led weaning group versus the spoon-feeding group. But in both of these studies, they had the parents report the weights from home, so there wasn't standardized scales in those studies. Since then, and since this article came out, there's been a couple more studies on risk of choking, and then several more on obesity and iron deficiency as well. So where did this study take place? I think this is student in New Zealand. When I Googled it, this is what came up, but I thought it looked really pretty, so I put it up there. So if anybody wants to go visit New Zealand, it looks really nice. There's hospital in Dunedin. I have no idea if I'm pronouncing that right, but the subjects all came from the single institution. There's a maternity hospital there is where they gathered their subjects from. They did have a lot of exclusions in this study, so anybody who didn't live local, from what it sounded like, there was a lot of people who came from other places, kind of like our hospital, so they had to exclude a lot of people that way. Any teen mothers, so mothers less than 16 years of age, were not included, and then booking after 34 weeks, because prior to 34 weeks, they needed to give them information and basically prepare them for the study before they had their child. So at 34 weeks or past, it was a little bit difficult to get them prepared for the study. And then anything premature. So any of our premature babies that were born, I believe their cutoff was 37 weeks. And then any congenital abnormality that could affect feeding or growth, obviously, because that could affect the outcomes of the study as well. And then they took the parity and the maternal education, stratified for those, and were able to separate those so that we had equal amounts of.
It's apparently Dunedin.
Dunedin?
Dunedin.
Dunedin. All right, there you go, guys. Dunedin, New Zealand. It looks like a beautiful place to go visit. I highly recommend based on the pictures. All right. So generalizing to our population, so just looking at the population that they looked at, there wasn't any significant discrepancies between the two. Obviously, the premature infants weren't included in this, so any of our premature infants in the NICU, born before 37 weeks, this may not be as applicable to. Take that with a grain of salt, you know. And then this population also seemed to have a little bit higher education level and a little bit more higher socioeconomic status based on the region that they were in. So especially some of our clinics where we see a lot more Medicaid patients like Jefferson, that would definitely be something to consider that maybe it's not as applicable to that population. And then teens were not included in the study either, less than 16 years of age. So we can't absolutely say that this would be applicable to them as moms either. All right. So the study took place, they recruited women from December 19th, 2012 through March 17th, 2014. And then they collected the data from July 31st, 2013 to April 26th, 2016. So this is a pretty long study, especially to get the number of participants they needed to be able to conduct the study. For how many years it did have a lower number of participants, just in the fact that they had a significant number of exclusions, including that booking after 34 weeks, which would be, you know, a lot of people who come in emergently, or if they haven't had any prenatal care or anything like that, you're going to miss a lot of people coming in that time. And I got to keep educating. So this is just a closer look at the eligibility and the inclusion for these patients. So they looked at 1,900 mothers that were assessed for eligibility. And the first cutoff, they excluded 839. As you can see, a significant number of them lived out of town, so they weren't able to follow them as closely, so they were excluded. A couple mothers less than age 16, and then some who had lost pregnancy or were just advised not to ask them. And then you had several that were greater than 34 weeks who were not booked before then. So with that, you were left with 1,061 potentially eligible, which were, again, excluded because they didn't either stay in the area for 2 years, infant was born before 37 weeks, other health reasons were applicable, and I guess they had 9 others. Then that left us with 214 that were randomized. I guess all the other people didn't want to participate in that study, so they ended up with 214 that were randomized into either the control or the BLISS group. The BLISS group is the Baby-Led Introduction to Solid Study Group. And I'll continue to reference BLISS as our Baby-Led Weaning group throughout the rest of the study, so BLISS equals Baby-Led Weaning. So ultimately, after several months of the experiment, a couple withdrew, some were lost to follow-up, so we ended up with 78 that were analyzed in the control group and 88 that were in the BLISS group. So definitely a smaller number of participants than what they had originally hoped for.
Do people agree with those criteria? Do they feel like the exclusions were appropriate? Did they go not far enough? Did they go too far? Do you think that the adoption rate of people agreeing to the study fits with around what you would think?
I mean, the raw numbers alone concern me as far as how much should I potentially, right? What? Less than a test. Again, So that alone.
So did they have good exclusion criteria? So what do you think? To try to tease out confounders for this potential intervention that may show a benefit. Are those pretty reasonable, you guys feel? So do you have your exclusion criteria?
Let me go back. Yeah, so our exclusion criteria is right here. So me personally, you know, some of them I feel like they had to do because just based on what the study looked at. You know, if they're not living locally, it's really hard to get them to bring the child in to get weighed. So that I wouldn't say it was overly strenuous in the fact that it just the feasibility of the study. And then the booking after 34 weeks, I don't know if that makes complete sense. I know they have to kind of prepare them for the study, but they're not actually doing their baby-led weaning until 6 months of age or even 4 months of age if you're looking at starting your typical feeding pattern. So I think that may have been a little strenuous. But prematurity, I think, would be really hard to measure just because those babies, you know, they get pushed back a little bit as to when they can start their feeding. So I think that one's probably accurate. I don't know if anybody else has any other opinions.
It looks appropriate. I mean, it limits your generalized, at least with a healthy, wholesome baby. A lot of good things in their favor that is.
There's a lot of things in those exclusion criteria that could confound your picture, and there's also a lot of things that factor into breastfeeding success that aren't accounted for in that exclusion criteria. So, like, for instance, what's the average socioeconomic class of Dunedin? That plays a big role. Mom in the house working, she out of the house, she available to the infant. Those all play a huge role. So, I don't know how you would adjust for that within the exclusion criteria.
Yeah, it looked like the majority of these families come from higher income, or if y'all saw that as well. And so you're studying a specific population, excluding these confounders, and does this intervention work for a randomized control trial? So reasonable. I think it's reasonable.
I think it definitely would have been more helpful if they had a couple more institutions, then they could have gotten a little bit of a larger number. I don't know, New Zealand is government-funded healthcare there, so I think that plays a little bit of a role into it. So I don't know how many other hospitals they have and how big New Zealand is. I'm not as familiar, but I think that definitely would have helped if they'd been able to include a couple more institutions, maybe get some more people. All right, so let's talk about their methods here. So initially they were randomized into the BLISS group or the baby-led weaning group, and then they also had the control group as well. The people who were randomizing as well as the researchers were all blinded to this as well. Obviously, the actual people participating in the study could not be completely blind because you had to give them directions on which one they were going to have to follow. And like I said, every mom had access to the government-funded midwives at the hospital as well as government-funded well child care after birth as well. There were sessions provided on lactation for both groups, although the BLISS group had 8 additional contacts to help prolong breastfeeding because they had to do that breastfeeding from 0 to 6 months, and that was the only thing they were allowed to have. And then most of this assessment for this experiment in this study was done by questionnaires. They assessed adherence and then outcomes by questionnaires 6, 7, 8, 9, 12, and 24 months. So lots of questions for these parents. They did do length measurements by the researchers who were blinded to it at 6, 12, and 24 months. And then this is where it varied from other studies, in the fact that the weight was measured by the researchers at 6, 7, 8, 9, 12, and 24 months, whereas the other studies, the parents had measured the weight. And then the BMI and Z-score were calculated at 12 and 24 months of age. Sorry? The researchers were blinded. Yes, so they did the weight, and they didn't know which group they belonged to. Is that your question?
So question is like, if weight measurement is by the research this week, that is not blinded, right?
In the
Yeah, it's in a blinded,
They just don't
it's
know.
not a double-blinded study.
Yeah,
They,
the parents know, but the
Okay.
the researchers do not.
yeah, and your midwives probably know as well, but they're not part of the study. They're part of the intervention, it looks like.
And you're going to come back to a pretty big red flag on that page later.
Probably. I'm not entirely
Well, one
sure.
picture hopefully it jumped out to everybody when they were reading. I'm sure.
Oh, gosh, okay. Hopefully I get there, all right.
Yeah.
All right, and then methods continued. So the primary outcome that they looked at in this study was looking at the BMI and the Z-scores for the BMI, but they also looked at several other secondary outcomes via questionnaires. The main ones that they used was a 8-question survey that they used to monitor energy self-regulation. So that was the child's eating behavior questionnaire, which measured satiety responsiveness, so how responsive they were to knowing that they were full, as well as food responsiveness, so just how responsive they were to food in general. Did they like it, did they not like it, the enjoyment of food, and whether or not they were picky. And then they also randomly assessed energy intake as well as one of their secondary measures. They would have them weigh food for 3 randomly assigned days out of a 3-week period. It include 1 weekend day and 2 weekdays, and they did that 7, 12, and 24 months as well.
Does anybody have a comment on that?
Why 7 months?
I don't really know why they chose 7 months. They didn't specifically say in the study that I found. I don't know if maybe New Zealand looks at their kiddos a little bit different than we do.
What about using weight as the... Go ahead.
Oh, no, I was just commenting on the age, like why
Yeah.
the age is like the availability of the children.
I mean, so how do we determine
Energy
calories?
intake is not by how much it weighs.
How do we measure calories? How do you know how much the Snickers bar?
How do you measure calories of gel?
Yeah.
It's the unit of energy to raise like 1 ml of water.
Yeah. So we burn it, right? We measure calories by burning stuff,
Right.
which you're not going to have the parents do, obviously. But, I mean, one of the biggest things is dry versus moist food will be a water content, which doesn't have water in. But, I mean, how else are you going to, I don't know. Is there a better way to measure calories from food?
That's kind of hard to say because especially they're going to be using a lot of like just a random sweet potato or a random avocado. That's hard to measure and you don't know how much the baby's going to eat.
Yeah, like, is there a gold standard for calories? And there's somewhat of a standard. Do y'all know what that is? Y'all heard of a method to see how much energy consumption is occurring in an individual? It's more so we sometimes use it in big academic centers for patients who are on chronic ventilators, but indirect calorimetry, where they measure kind of their CO2 that's blown off, they weigh on this complicated stuff. And it's hard to get that done. Is that even a good surrogate for that? Is that even a valid approach? That's the question I would have. Weighing food 3 random days out of a 3-week period.
I don't agree that this is a good way to do that because, of course, the parents are going to be, more biased in that aspect. Oh, we have to weigh our food today. We need to make sure that we have the right amount and that we're weighing it perfectly and that this is going to, if you know you're doing something, you're going to have a bias towards it as well. So I absolutely don't think that was the right way to go about it. I don't know that there is a right way to go about it, but. So I think I mentioned at the beginning that due to some of the issues with concerns for the baby-led weaning, they did do their kind of like modification for this study just to make sure that we're having that adequate iron intake and not choking and all of that stuff, which I think are all pretty straightforward that we would all give in our general practice when we're telling parents about just feeding their kids in general. But they worked on was testing foods before they're offered to make sure they're soft enough. So they said you can either mash it with your tongue, the roof of your mouth, or like kind of squish it between your fingers. And then like strips of meat, they're large and fibrous enough that small pieces don't break off when they're sucked or chewed. You want to avoid offering foods that crumble in the mouth, so things like saltines or, you know, like biscuits can kind of crumble a little bit, anything like that. Make sure that the foods are long enough, as long as the child sits, at least on one side. Infant should be sitting upright, preferably a high chair, but I guess you can put them in mom's lap if you want to as well. Always have an adult nearby when you're feeding. Never put whole foods into the infant's mouth. The infant should be doing this under their own control as well. And then also encouraging parents to offer 3 food types at each meal, an iron-rich food like red meat or an iron-fortified infant cereal, energy-rich food, and then a food such as a fruit or vegetable, which again goes kind of against our typical approach with traditional spoon feeding, because then you're only offering one thing at a time versus multiple things at a time in this approach. So, potential issues with the study. So this study relied heavily on parental opinions and completion of surveys. So the parents obviously knew which group they're in, so they know this is a new baby-led weaning approach, and they think it's awesome. They want to write all the things that they want to write and score higher, or they could score lower if they don't like it. So definitely a little bit of bias in that aspect. The other thing is that this BLISS group received significantly more assistance in regards to lactation than the other groups, which I think can also play a confounder, because, you know, we look at our babies who are breastfed, a lot of times, you know, we say that breastfeeding is the best thing for our babies, so is that also a confounder in there that maybe these moms breastfed a little bit longer and had a little bit more help, were able to give their babies a little bit more the nutrients that they need via breast milk as well, just something to consider in that. And then again, longer time of exclusive breastfeeding, the BLISS group, when you're going to kind of start introducing solids at 4 to 6 months in a traditional spoon feeding group as well. And I think there's a couple other things that I'll touch on a little bit later, but those were the ones that jumped out at me right away just looking at the methods. And then we talked about the energy requirements already.
I mean, hopefully that second one, that was what I was mentioning earlier. I mean, anytime you're intervening upon one group and not the other, you ask yourself, is that influencing the study? And just like you said, so is actually the longer breastfeeding that leads to a difference, if the difference is out there. But also, I mean, time after time, studies have shown that the more you intervene with the population, like the more likely you're going to have some outcome, right? If you just have 2 groups, one, they just have somebody that comes and talks about the study once a week with them versus not. Is that alone enough to raise the parents' awareness, make them more compliant, change the outcome or not? Like you're providing a different level of intervention and support for one group.
Exactly.
Like an intervention bias.
Intervention bias.
There's a
Exactly.
Hawthorne effect. You know you're supposed to study.
Yeah. Okay.
Well, also you have like, one thing that it kind of left out, but if you don't, you know the intervention taken there, but you don't, for this study, know the intervention taken from the child health care providers. It does talk about like they had access to the same government-funded midwives and, you know, healthcare system, but there's a significant private healthcare system in New Zealand, and if this is a well-off socioeconomic class, you don't know who is making visits to those people either, and what information they're using. So there's a lot of possible education that could have occurred.
Was there a reason to not provide lactation consulting at that same degree to the control group?
And they didn't mention any reason not to, and I don't really see a reason not to, other than the fact that, like, it was very specific that that group had to breastfeed till 6 months, and if they didn't, then that was going to be an issue. Then that would have found other variables. So, yeah, absolutely.
It's just that, I mean, anytime you can even the playing field between your groups, it's going to reduce the sense of bias.
All right, so a little statistical sidetrack here. Told you guys there's going to be lots of babies in this one. So just a refresher on Z-scores, not necessarily like a measure that it was a measure that they focused on for BMI. I know we use this a lot, but, you know, just a little refresher to talk about what that means. But a Z-score is a measure of how many standard deviations below or above the population mean a raw score is. So you can use this to compare a value to a population. And then again, the number of standard deviations above or below particular values. Typically ranges from -3 to 0.3. And then you can calculate it by Z equals X minus mean divided by standard deviation. I can't remember what those symbols are called, but that is the formula here.
What's the letter?
Yeah.
U and sigma.
U sigma, well, there you go. Thank you, Dr. Pinkler. All right, so the main results of the study were the BMI results. That's what they were initially looking at. So looking at the BMI at 12 months, they found that the Z-score was 0.21, with a 95% confidence interval of -0.07 to 0.48. What do you think about that confidence interval? Yep, perfect. Yep, it crosses the 0, so we consider that not significant, because then that means that it could possibly be on one side, it could possibly be on the other side. And then same thing with the BMI at 24 months, the Z-score of 0.16, same with the confidence interval crosses 0 at that point as well. So they found that there's no difference between the control and the BLISS study in regards to Z-score BMIs. The relative risk for this was 2.5, with a 95% confidence interval, 0.9 to 6.9 at 12 months, and then 1.8 at 24 months. So relative risk greater than 1 usually indicates that there's a greater risk in the BLISS group for risk of disease, which is kind of the opposite of what we initially thought and what some of the other studies have showed too, but we're also looking at a confidence interval that is not really going to work for us. So that was kind of surprising in this study as well.
I think that range also for the relative at least helps you emphasize a bit.
Yeah, with only a couple.
Say that again.
That the sample size was definitely significant issue for the study. It's a very large range of confidence interval, so that even if there was significance, you're probably not going to find it. It's not powered well.
And then just looking at some of the other secondary measures, and keep in mind, these were all by questionnaires, so there can obviously be some bias in there. But from what they found, the satiety responsiveness, so being able to determine like whether they are full and that they were able to eat enough, the BLISS infants were found to be less satiety responsive, which is kind of the opposite of what they thought. And that confidence interval was actually significant, but it didn't cross 0 in that aspect. The food fussiness, how picky they are, ultimately they found that they were less fussy at 12 months in the BLISS group, and then actually no difference at 24 months based on the questionnaires. And again, those confidence intervals were both on the negative side, did not cross 0, and those were the two questionnaires, the CEBQ and the TMBQ questionnaires as well. And then in regards to the choking events and iron deficiency, they didn't really find the difference between the two groups in regards to those either.
Was that a reported iron deficiency? They didn't actually measure iron?
I believe it was just reported. It wasn't, I don't think that they actually measured the iron.
Okay.
So just a couple graphs to look at here. So this is the age at introduction of complementary foods, which you have the age down here and then the proportion up here, and so the control, obviously they're going to start introducing a little bit earlier because that's our traditional spoon feeding group, whereas the BLISS, they're all supposed to start right at here about 6 months. So right at 6 months, they're all far. And then the age at which we're self-feeding regularly, and again, these are all kind of self-explanatory based on what we're looking at in the study, but again, you have the age here and the proportion up here, and then the BLISS group should be all feeding themselves regularly. That was the point of the baby-led weaning, is that they feed themselves, they're using pincher grasp and able to do that all on their own. Some babies, it sounds like, maybe weren't quite up to speed with everybody else, and then the control, again, they're not really introducing the pincher grasp until later, and so you have the control here. And then, again, age at which they're self-feeding all of their food, same thing, age, and then the proportion up here. So your BLISS is going to be feeding most or all of their food. This has to account for, like, the breastfeeding as well, so they're obviously not going to be breastfeeding themselves. And then the control as well, down here is going to be a little bit less because they, again, were spoon-fed for a significant amount of their time, so they may not be as caught up. So just briefly touching on the adverse events that occurred during this study. So there are 2 severe adverse events reported, one in the control group and then there's one in the BLISS group. These were both choking events, but they were found not to be related. Both of them were on milk, required hospitalization, and I couldn't really find how they determined that this wasn't related, but I guess since it was milk and not them actually eating the solid food, that it wasn't counted. And then there's 11 passive reported adverse events. So these were all things that were just kind of noted as parents went along, either in the questionnaires or at their well child visits. We had some constipation, choking, deficiency of milk intake, growth, and potential food allergy as well. And then we'll talk briefly just about growth triggers, because that was another thing that they were worried about is, are these kids going to gain enough weight? Are they going to be able, in the BLISS group, to be able to maintain their weight and feed themselves enough? So there were what they called growth triggers, so that was just essentially a weight that was like below where they should be at a specific time when they came in. There's 16 of those in the control and 16 in the BLISS, and essentially what happened is they all showed improvement over time, so it's kind of just like an outlier, and then eventually they were able to catch up and didn't have an issue. So strengths of the study, it was a randomized clinical trial. That's not right, it was not double-blind, but it was blinded to the researchers and those who were doing the weight and the statistics. And then again, the weight of the patients was attained by study officials instead of the parents doing the weight on their own. So they had a standardized scale that was able to be used each time. And then limitations. Also, does this give anybody like anxiety looking at this baby completely covered in baby food? Because it gave me some anxiety. So again, we've kind of touched on this a lot since we've started, but this is definitely a small sample size. It would have been helpful to get a couple more institutions involved. We discussed already kind of the exclusion criteria and how we thought that was relatively, Dr. Borwitt says it gets worse when they start throwing food. So definitely a small sample size. And then they talked about the growth faltering. A lot of that was in descriptive terms. So if the parents were thinking like, oh, my baby's not where they're supposed to be, again, it relies a lot on questionnaires instead of actual measurements except for that BMI. And then again, we touched on this earlier, this was a very socioeconomically advantaged population. So you had a little bit higher education status, you had a little bit higher level of socioeconomic, and then again, this was a modified approach to baby-led weaning. So the typical baby-led weaning, like we said, is just, you know, they eat what you eat, make sure it's soft, that's kind of it. And this one, they were a little bit more specific about what that meant and giving parents a little bit more guidance in regards to like what babies should be eating, what should be included in their meals. So they didn't look at just like the traditional baby-led weaning. Right. So overall picture for this study, there doesn't really seem to be a difference between the baby-led weaning group or that BLISS group and the spoon-feeding group with regards to BMI at 24 months of age, which is different from the last 2 studies that were done prior to this. The concerns initially that were the choking and the iron deficiency aren't as much of a problem. There's only the 2 adverse events of choking, both of those were on milk. And then the iron deficiency, like Dr. Finkler pointed out, is that they didn't measure it by, you know, checking actual blood levels or anything like that. It was just all based on parents, so there could be some room for further research in regards to that. And then we also talked about concerns for infants not eating enough initially, and then it showed pretty similar between the 2 that they didn't really fall off the growth curve, and they did seem to have adequate growth throughout as well. One thing that did come out of this is they showed that the BLISS group was a little bit less food fussy and enjoyed their food a little bit more at 24 months. So if you take nothing else from this study, because it wasn't the best study, at least maybe your baby might not be as picky at 24 months and enjoy their food a little bit more. So talking about our patients at Carilion. So you have your parents come in, can I safely do this baby-led weaning with my child? And I think the answer, going off of this study and several other studies that I looked at, there's not really a right answer. You kind of have to do what's best for your child. But especially looking at what they did in this study with the specifics of their modified approach, I think would absolutely be fine to, talk to your patients about and just making sure that there is like a safe way to do this and that they are getting enough iron and a pretty balanced diet. And then again, dependent on patient population, we do have a different patient population at like our Jefferson Plaza office versus our Coastal, which I guess Jefferson is now Tanglewood. So you have to keep that in mind when you're talking to parents about this, making sure that they have the means to be able to do this, because it does take a lot of close attention to be able to do this baby-led weaning approach. But ultimately, it's a decision between the parents and the pediatrician on what's best for their child. And Dr. Blewett can be helpful. Oops, I lost it. I'll look at it in a second. And then just discussing, they didn't use formula in this. So we have a very large population here that uses formula. So is this still going to be the same result with the formula? And how does that play into this? So there's definitely some room for further research and discussion with our patients here at Carilion as well. Dr. Board said, can be helpful to educate yourself on how to do it if parents are asking. She bought a book before we started doing it with Dave last year. Awesome. All right. And then just some points to pass along, just for all our general pediatricians and anybody else here. Starting with simple foods one at a time can be really helpful. Especially when you're looking for allergic reactions. You want to make sure when you introduce foods that, you're not introducing a bunch at one time. That can make it difficult. It can take up to 15 times for your child to decide that they like something. So keep offering it to them. Don't just give up after they take it one time and throw it across the room in your face and say, no, I don't want this. Again, avoiding juice, cow's milk, and honey before the age of 1 are always necessary. Encouraging family mealtime with the baby, and then since apparently my last journal club was also on food and infant, there's a theme here. You can introduce peanut butter less than 1 year of age, and this child definitely got into peanut butter here. So I think, let's see, references, and any questions?
So I was going to ask our medical students, so is this, what would you classify this study as? Is it a positive study or a negative study?
Don't be shy. They won't offend me.
So you mean good or bad by that?
So positive results, like the intervention showed if there was a benefit or not. What is it? Yeah, so we would call that a kind of a negative study. It didn't show an outcome that it was benefit with the intervention. It's important that these things still get published, because you do a research project like this and you don't show an outcome. But there's some validity to a negative study, such as this. And then the other question I have is, so when it goes to type 1, type 0, type 1 error, are y'all familiar with those terms?
Type 2.
Type 0. Type 1, type 2 error. Yeah, so let's assume that they are correct with their null hypothesis. What type of error is this? They assume that there's a difference, and then with the study they rejected it. You're going to ask that more confusingly.
Rejected the null, or what are they rejecting?
So tell me the difference between a type 1 and a type 2 error. Okay. So what goes along with this is that perhaps that they thought there was a difference, and then, so this would be kind of a type 1, assuming they didn't make that error, okay? What is a type 2? Explain that.
Type 2 is when they fail.
They failed to reject the null hypothesis. They failed to reject that, so they assume that there's no difference. There, in fact, is a difference. So with this study, could this intervention actually be beneficial to other populations or other, like, external validity? And the other question I have is, they looked at 12 months and 24 months. So was that enough is that an appropriate measurement? I think we mentioned that earlier. I guess I missed the background on it for the obesity aspect of it. Is there something to suggest in the literature that your BMI is, this and that at
I didn't
24 months?
see anything that said that this would like predict further on. I think they just
really?
kind of use that as kind of this is where our study needs to end, but I'd have to go back and look. I don't remember seeing anything about that.
So then the other question I have is why are we looking at markers at 24 months and 12 months if there's no association with obesity long term? Why are we really measuring that? But the thing is, so yeah, this is a negative study, but you're using a select population of folks in New Zealand, higher socioeconomic class, majority from Eastern European descent. This may benefit other families or other patients in that, some of the ones that were excluded. So like you're saying, other studies would need to be done, and doing a multi-center is going to cost money, or maybe trying it on more socioeconomic deprived individuals. You may actually see a benefit with that. This lacks external validity because of how fine-tuned they were with the select population.
And I've also mentioned that typically, we do see in the higher socioeconomic status maybe there's less obesity. So if it's not tested on our lower socioeconomic status where the true why obesity is, there may actually be something there. So that's a really good point.
Dr. Gillman, please remind me, when they reported the relative risk in their statistical analysis section, did they address if they calculated the relative risk with respect to modification, meaning that they tried to control for the confounding factors, or maybe if there was manual handling anywhere in there, something like that?
I believe that they did. I'd have to go back and look specifically, but they did do some modifications based on the fact that some people dropped out. So I'd have to go back and look. Did they send you guys out the article?
Yeah. The statistics part of it, it's important to look at that. And I'm simple when it comes to that because statistics is very complicated. But if it's a complicated statistical test that you're very unfamiliar with, they might really be digging for data and trying to tease something out.
Like my last article.
Yeah. So, simple student t-test, Man-Whitney, those are kind of very easy. You almost can, I think, do it on Excel. When you start getting into these more exotic ones, it's harder to understand, and it may be that it's challenging to really interpret what that means when you get a statistically significant result with those types of studies. And then there was we couldn't see your graphs when you sent the article out because I think it was in a different format and wouldn't link it to the tables. But this is a negative study, but there may be something still that you can gain from negative studies. Like if you go back, there was one graph you had, go to the right, one more. So right here, age at which self-feeding all or most food. This seems, having not seen the graphs, I was thinking this study, there's not much to get out of it. But seeing this graph, there may be something to that this child can be a little more self-reliant with this intervention, and it frees up the parents or frees up the mom, and maybe they're getting off the breast milk, earlier. So there may be something to actually with this graph right here that may be a positive result in a negative study.
Right.
Theoretically, to be training more fine motor skills early.
Yeah.
There's developmental, benefits probably in this as well. Yeah, independent, confident,
Yeah, because you're seeing, and it's only half of them, right, with our big spike up in our BLISS yellow line, as compared to a quarter of them. And then you've got a spread of, 25 versus 40 weeks. That's kind of impressive. You can get get this kid to do something a month and a half earlier or sooner. That may actually benefit the family. Actually reading the studies, not seeing the table does, like, I don't see any positive, but seeing this graph right here, I would almost promote doing working on their fine motor skills on the earlier side and getting them more independent, which may have some benefits to the family.
All right, thanks, guys. Great discussion.